Hi class, and welcome to chapter 19. And if you've been following us so far, you've been noticing that through these PowerPoints, even though there's about 6 chapters we cover in this module, I've really been trying to just highlight things that I want you to know. The heart is a big one that I want you to know. So do spend some time on the heart, especially understanding all the anatomy of the external and internal side of the heart. So the heart is a muscular double pump. It has 2 functions: to pump blood in the pulmonary circuit, where the right side will receive oxygen poor blood from the body and pump it to the lungs, and the systemic circuit, where the left side receives oxygen blood from the lungs and then pumps it throughout the body. The atria are the upper chambers of the heart that receive blood from the pulmonary and systemic circuits, and the ventricles are the lower chambers of the heart. These are the pumping chambers. So here's the heart acting as a double pump, and you can see this here, how the systemic circuit pumps oxygenated blood to all of the capillary beds where tissues and gas exchange occurs. And then the right side of the heart will pump through the pulmonary circuit to the lungs, where the blood will pick up oxygen. The heart, a healthy heart typically weighs between 250 and 350 grams. It's the largest organ in the mediastinum, which is the area located between the lungs. The apex lies to the left of the midline, and the base is the broad posterior surface. So here's where the heart lies in the body, in the thoracic cage. You can see the apex and how the heart is kind of rotated on itself with the apex pointing down. You can also see it in a cadaver in this picture as well. There's 4 corners of the heart: the superior right, superior left, and inferior left. And you can see where these are located. The pericardium is the covering. It has 2 primary layers. The fibrous pericardium is the strong layer of dense connective tissue, and the serous pericardium forms 2 layers: the parietal layer of the serous pericardium and the visceral layer of the serous pericardium. And this is just the layers of the pericardium and how we describe the heart wall. So you can see here the fibrous pericardium, and then you can see here the parietal layer of the serous pericardium, which will line the body cavity itself. Then you'll have a pericardial cavity, or a space between the two. And the epicardium is then considered the visceral layer of the serous pericardium, the one that will cover the heart organ itself. The myocardium is the thick muscular wall of the heart, where all of the cardiac myocytes will be. And then the endocardium is the inner smooth surface of the heart chambers. So here's the epicardium, the myocardium, and the endocardium. You guys should know these 3 layers of the heart wall. Here is how the circular and spiral arrangement of cardiac muscle will bundle in the myocardium of the heart. And these bundles help to kind of squeeze or contract the atria and ventricles so that the heart can be very efficient in the pumping out of the blood. So here are the heart chambers. Again, we have the atria, the superior chambers, right and left, and they're named right and left for how they would sit in a patient's body. The right and left ventricles are the inferior chambers, and then you have internal divisions, which are like walls between the chambers. The interventricular septum is the wall between ventricles, and the interatrial septum is the wall between atria. The heart has external markings: the coronary sulcus, the anterior interventricular sulcus, and the posterior interventricular sulcus. And these sulcuses are kind of grooves within the heart between those chambers. So here's a great animation of a rotating heart. Again, use those animations to help even with lab, but especially even in lecture. I will be asking you some labeling questions on the heart. So be sure that you know how to label the different structures on the external and internal surface very well. So here's the gross anatomy of the heart. We can see the right atrium, the right ventricle, the left atrium, and the left ventricle. And you can see here these little auricles. They look like ears. They're like extra pieces of tissue that cover the atrium. So that's why the atrium have these little kind of covers called auricles around them. We can see the different coronary arteries running through the sulcuses or sulci, the grooves. Here we have the superior vena cava entering into the right atrium. The inferior vena cava also enters into the right atrium. The aorta has kind of an ascending aorta, an aortic arch, and then a descending aorta that travels down. These 3 pieces coming off of the aorta: the brachiocephalic trunk, the left common carotid, and the left subclavian arteries. The right pulmonary veins, left pulmonary veins bring oxygenated blood into the left atrium. And then the pulmonary trunk divides into a right pulmonary artery and a left pulmonary artery, which takes blood to the lungs to pick up oxygen. So the right atrium will form the right border of the heart. It will receive oxygen-poor blood from systemic circuit through these vessels, the superior and inferior vena cava and the coronary sinus. The right atrium has pectinate muscles, which are ridges inside the anterior of the right atrium. The crista terminalis is a landmark used to locate veins entering the right atrium. And the fossa ovalis is a depression in the interatrial septum, the wall between the atrium, which is a remnant of the foramen ovale, which is a hole that's formed during fetal development for blood to pass through the atria, each from right to left, to bypass the lungs, because in fetal development, a baby's lungs aren't developed to receive blood yet. The right ventricle then receives blood from the right atrium through the right atrioventricular valve, also known as the tricuspid valve. The right ventricle will then pump blood into the pulmonary circuit via the pulmonary trunk, which will take deoxygenated blood to your lungs to pick up oxygen. The internal walls of your ventricles, specifically the right ventricle, has trabeculae carneae, papillary muscles, and chordae tendineae. The pulmonary semilunar valve is located at the opening of the right ventricle and the pulmonary trunk, which blood will pass through into the pulmonary trunk to go to the lungs. Here's then the left atrium, which makes up the heart's posterior surface. It will receive oxygen-rich blood from the lungs through the pulmonary veins. It opens into the left ventricle through the left AV valve, also known as the bicuspid valve, because there's two kind of flaps to it. It's also known as the mitral valve. So you'll see mitral valve often referred to for the left atrioventricular valve. The left ventricle then forms the apex of the heart. The internal walls of the left ventricle are very similar to the walls of the right ventricle. Papillary muscles connect to chordae tendineae, which are like heart strings that will connect to the valves. The left ventricle will pump blood through the systemic circuit via the aortic semilunar valve, or the valve opening, so that blood can go through the aorta. So again, these animations are great. Take a look at those to help your studying. And here's a posterior view of the external surfaces of the heart. The coronary sinus drains all the blood from the heart directly into the right atrium. Here we can see the pulmonary veins left and right entering the left atrium, the pulmonary artery, right pulmonary artery. So it's just good to see another view of the heart from a posterior view. So looking at it posteriorly, these are all the structures on the right side, and these are all the structures on the left side. Internal structures, this is again a really famous picture that a lot of textbooks use. So you can see the valves, and you can also see the other muscles inside the valve. So we have the chordae tendineae, which are strings leading up to the atrioventricular valves, and they're attached to papillary muscles. And when these papillary muscles contract, they put tension on the strings, which keep the valves closed. And then you can see here the pulmonary valve, the aortic valve, the mitral bicuspid valve, the interventricular septum. So you can see here many of the internal structures of the gross anatomy of the heart that you should be well familiar with. The heart valve, so the valve structure is composed of an endocardium with connective tissue. These, you should know well, the valves, the atrioventricular valves are between atria and ventricles, and they are called tricuspid on the right side and bicuspid or mitral on the left side. The aortic and pulmonary valves are at the junction of the ventricles and the great arteries. The cardiac skeleton surrounds all four valves. It's composed of dense connective tissue. It anchors the valve's cusp, prevents overdilation of valve openings, and it's the main point of insertion for cardiac muscle, and it blocks the direct spread of electrical impulses. So here's a look at the cardiac skeleton and how it kind of keeps and handles the valves in place. Here's a look at the function of the atrioventricular valves and just how blood returning to the heart fills the atria, presses against the valves. This increased pressure forces the valves to open, and then the ventricles fill. And as the atria contract, they force additional blood into the ventricles. Here's a look at the function of the AV valves during ventricular contraction. So as the ventricles contract, they force blood against the AV valve cusps, so then they close. The papillary muscles contract, and the chordae tendineae tightened to prevent the valve flaps from entering the atria, so keeping everything closed so that blood doesn't flow back into the atria as the ventricles contract. Here's a look at the semilunar valves as they will eventually open when pressure builds up high enough in the ventricles, and the ventricles contract to force blood out of the ventricles into the made blood vessels, the aorta and pulmonary trunk, and then they will close again so you don't have blood flowing back into the ventricles from where it came. The heart sounds make the lub-dub, lub-dub, lub-dub that the doctor listens for in the stethoscope. The first sound is the lub sound, which is the AV valve closing. And the second sound is the dub sound, and that's when the semilunar valves close. And the doctor listens to make sure your valves are closing all the way. If he hears a whooshing noise or some extra heart sound, that signifies that the valves are not closing all the way and blood might be going back into a chamber from where it came from. And that would greatly decrease the efficiency of the heart for pumping out the blood. So they want to make sure your valves are closing consistently and all the way. Each valve sound is best heard near a different heart corner. So the doctor will listen for these different heart valves in 4 different places on the chest to hear the valves closing. So if he's doing it right, your doctor should listen to your heart in 4 different places at each of the 4 valves. So you can ask him next time to see if he's doing that. Pathway of blood through the heart then, it begins with oxygen poor blood in the superior and inferior vena cava. A blood drop passes through all the structures sequentially. The atria will contract together and the ventricles contract together. And this is the pathway of a drop of blood throughout the heart, and oxygen poor blood is in blue and oxygen rich blood will be in red after it goes to the lungs to pick up oxygen. So feel free to pause the lecture video and make sure you know this pathway going from the right atria to the right ventricle to the lungs, back to the left atria to the left ventricle, and then to systemic circulation. Heartbeats are about 70 to 80 beats per minute at rest. Systole signifies the contraction of a heart chamber, and diastole refers to the expansion or relaxation of a heart chamber. Systole and diastole also refer to the stage of the heartbeat when the ventricles contract and expand. The structures of the heart wall, so the walls will differ in thickness throughout the chambers. The atria have much thinner walls. The ventricles have thick walls. The systemic circuit is longer than the pulmonary circuit because it has to go to the body. The pulmonary circuit just has to go to the lungs, which is very close to the heart. So the systemic circuit offers a greater resistance to blood flow. The left ventricle has the thickest wall, and that's because it exerts more pumping force. Your left ventricle is what is pumping out the blood to the entire systemic circulation. And you can see that here, some anatomical differences. You can see the left ventricular wall is much thicker than the right ventricular wall. The cardiac muscle tissue then, it forms the myocardium layer. It's striated. The contractions of cardiac muscle tissue will pump blood through the heart and into the blood vessels, and it contracts by the sliding filament mechanism. I don't think I asked you guys too many questions about cardiac muscle cells, but you should remember from chapter 4, they're short, they're branching with 1 or 2 nuclei. They are joined by intercalated discs, which that might be a test question. These are complex junctions that form cellular networks. The cells are separated by delicate and endomysium, which binds adjacent cardiac fibers together, containing blood vessels and nerves. These intercalated discs, they're complex junctions that connect heart cells together. They're desmosome-like. They're gap junctions, and they are important because they allow ions to pass through your cardiac muscle cells just so that your cardiac muscle can contract as a unit. So these are intercalated discs, very important. I think that is a test question. And you can see here that intercalated discs are these little gap junctions, kind of these darker lines connecting cardiac muscle cells together. And you can see how cardiac muscles are also striated. They will contract via the sliding filament theory that we learned about. The mechanism of contraction, you guys don't need to know, but it's similar to skeletal muscles using calcium and the sliding filament mechanism. The conducting system of the heart, the cardiac muscle tissue has the intrinsic ability to generate and conduct its own electrical impulses. And the signal to these cells signals to them to contract rhythmically in a heartbeat. The conducting system is a series of specialized cardiac muscle cells, and the sinoatrial or SA node will set the inherent tone of contraction. From the SA node, the electrical signal travels through the internodal pathway to the AV node. The AV node will then send the signal down to the AV bundle as it travels into the ventricles. The AV bundle will branch into bundle branches. Lastly, the bundle branches will kind of branch into all ththese Purkinje fibers, which take the electrical signal to all the cardiac muscle cells in the heart. So here's the intrinsic conduction system of the heart and the pathway of these electrical impulses starting in the SA node, going to the AV node, and then traveling through bundle branches up into the walls of the heart. Innervation of the heart is altered by extrinsic neural controls, which can come from visceral, parasympathetic, or sympathetic fibers. Nerves will pass through the cardiac plexus. I don't think I asked you guys any questions about these, but the parasympathetic fibers are branches of the vagus nerve to decrease heart rate, and the sympathetic nerves work to increase heart rate and the strength of contractions. Autonomic input is controlled by cardiac centers in the reticular formation of the medulla in the brain. I don't ask you guys questions about this. Blood supply to the heart. So your blood tissue needs blood supply itself. So blood supply to the muscular walls and tissues of the heart is by the right and left coronary artery, and it arises from the base of the aorta, runs in the coronary sulcus. The left coronary artery branches into several different arteries, and the left anterior descending artery, LAD, is a clinical name for the anterior interventricular artery. And this is often the artery that sometimes gets blocked, which we'll talk about either in this chapter or the next one. Here's the right coronary artery, cardiac veins. So these are veins that will carry deoxygenated blood from the heart wall to the right atrium. They'll all drain into the coronary sinus, which will drain all the blood into the right atrium. You can see the main tributaries of the veins that drain into the coronary sinus. So here's coronary circulation, arteries and veins of the heart. Disorders of the heart, we have atherosclerosis, which are fatty deposits in the heart or in the coronary arteries. These can lead to blocks because they'll build up and cause a block. Angina pectoris is chest pain. Myocardial infarction, or an MI, is a blocked coronary artery, which will cause a heart attack. And silent ischemia usually means some sort of damage to heart tissue with no pain or no warning. Heart failure is progressive weakening of the heart where it cannot meet the body's demands for oxygenated blood. Congestive heart failure is when the heart enlarges and pumping efficiency declines. And pulmonary arterial hypertension is the enlargement and potential failure of the right ventricle. Arrhythmia is a variation from normal heart rhythm. Ventricular fibrillation is rapid, random firing of electrical impulses. This can result from a crippled or damaged conducting system, and this is a common cause of cardiac arrest. You can have atrial fibrillation, which are impulses circling within the atrial myocardium, leading to strokes. Occurs in episodes characterized by anxiety, fatigue, shortness of breath, or palpitations. Here's development of the heart, which I don't ask you many questions for. It is interesting to see the development of the heart real briefly in the fetal, because this foramen ovale is a hole that's between atria so that blood can pass directly from the left to the right atria. That's important because blood can't go to the fetal lungs yet because they are not developed. Congenital heart defects can be traced to month 2 in the development. The most common defect is a ventricular septal defect. So the wall between ventricles isn't there. There can be inadequate oxygenated blood reaching body tissues, so the ventricles will labor under an increased workload. So here are some congenital heart defects. I don't ask you guys questions, but it's a little interesting to take a look at this and spend some time. You can see here how often it occurs in 1 in 500. So you can go through that on your own. The heart in old age, then the heart usually functions very well throughout life. Regular exercise increases the strength of the heart, and aerobic exercise can help clear fatty deposits in the coronary arteries. Those fatty deposits can lead to a blockage, which could lead to a heart attack. Age-related changes, there's hardening and thickening of the heart wall cusps, decline in cardiac reserve, and fibrosis or scarring of tissue of the cardiac muscle. So that's it for this chapter. I'll see you guys for one more chapter on blood vessels, and I hope you're all doing well.